Okay, so my topic today is portable ventilator. So basically, this lecture I do for the novice non-ICU doctors or anybody who has got a lot of experience in ventilation. I don't think this part is for you guys, but so for the very new doctors at this particular moment, we get a lot of doctors to manage patients which actually they don't have enough critical care background, but in this disaster kind of situation, so we get their help to manage these patients. So one of you might need to ventilate a patient using probably a less frequently used ventilators like portable ventilators. So my idea here is to let most of these non-ICU doctors to use portable ventilator. So I'm going to talk only extremely basic stuff about the ventilation. So I might have to, I'm actually changing the way I teach today. So I'm actually summarizing what is extremely important uh, to minimize the harm, at the same time to have a better learning curve in managing a portable ventilator. Because most of the time I mean ward setup, because you won't get ICU ventilators, so you most of the time you have portable ventilators, especially for transport purposes. You have portable ventilators in most of the medical wards, and we are getting more and more portable ventilators, so that you will need to use one of these ventilators. So what is the place of portable ventilators in our country? Because ICU beds are limited, and they are most of the time they are occupied most of the time, and it's kind of becoming difficult to find an ICU bed, especially for this because of the COVID and non-COVID patient load. Uh, the other thing is the pulmonary phase of COVID. Now we actually see more and more people with need to more invasive and more advanced kind of respiratory management. And some of these patients which I discussed last time about the NIV and high flow nasal cannula oxygen, sometimes some of these patients may not become better, they don't do well in these modalities. And certain times if you know how to ventilate, sometimes it's maybe a good idea to protect the lung by early intubation, as Dr. Anoma discussed. So it's not a very clear cut decision at the moment, because in this hypoxic COVID situation, because people have different opinions. Basically, what I generally think is, if you have enough experience in managing and you have the kind of staff experience, probably early intubation may help if you do it properly, but you look after the patient after intubation. But in a ward situation, this may not be the case, where you don't have enough expertise in managing an intubated patient. So the outcome would depend on how the patient is treated. Now, the good thing about the portable ventilator is, so it is not a very intimidating device like a ICU ventilator. It has got very basic settings, but at the same time, it can provide some level of sophistication of ICU ventilator. Nowadays, the most of the portable ventilators, they are fairly, they can provide some most of the ICU required facilities in a ventilator. So, but there is some kind of change, I would say, in ventilation under less experienced staff, because you generally, once you learn about ventilation, you realize that you need some kind of expert knowledge in saving a patient. You can ventilate, but to save a patient, you need expert knowledge, and you need trained staff, including nurses, doctors, and you need a suitable environment in ICU environment, where you have all the facilities to monitor the patient and then do blood gas, things like that. At the same time, if you use these portable ventilators inappropriately, it can actually harm the patient very easily, because I told you last time, in a invasive ventilator, there is no free flow of air or oxygen coming to the patient. The patient must tell the ventilator, or the ventilator must open the valve to give oxygen or airflow to the patient. So intubation is a kind of a special situation. Once you do that, it's completely enclosed environment. unless the ventilator opens the inspiratory valve and provide some flow, the patient cannot breathe. They can try to breathe, but they won't get any air from the ventilator. So it's extremely important to know what to do when you intubate the patient, how to make sure that the patient is getting what the patient wants. Okay, so as this is a kind of a difficult thing to do within a short period of time, I thought of providing some kind of guidance or how to learn this thing. So first thing is you have to, if you see a patient, you have to see what the patient's basic requirement. Are they breathing faster? What kind of minute ventilation? Ventilation means the number of volume. I mean, the amount of gases. Like we call one breath, the volume of a breath, tidal volume. And if you multiply that one by the respiratory rate, you will get the amount of gases going in or out per minute. That is what is needed to, that's what we call ventilation, minute ventilation. When you look at the patient to see how much minute ventilation generally they require about 100 ml per kg in a normal situation, like in a, say, in a 60 kilogram person, it would be about 6 liters. So you can get 6 liters in, say, 500 ml into 12 or 600 ml to 10, things like that. You can have various combinations, but that ventilation is important. So what do we have to provide using this ventilator? Can I provide that minute ventilation? That is the patient's requirement. So you have to have some idea about patient's requirement. And then you learn the ultimate basics of setting up a portable ventilator. This is what I'm going to teach you today. So I'm not going to go into fancy details, but the most important settings, because when you see a ventilator, sometimes it's quite intimidating for a novice person, because you see a lot of parameters which you haven't even seen, heard, and then what to do with it. So I'm going to summarize the most important stuff so that you can forget about the rest, and then advanced operator probably can change those things, but I'm going to stick to the most basic ones. And then before you do ventilation on a patient, first of all, if you have a say portable ventilator in your ward, make sure you test the whatever you are going to do with a test lung before you apply. You don't have to do it every day, but I'm saying when you learn, first thing is to get a test lung. If you don't have a test lung, you can get a reservoir bag from the anesthesia theater. Or you can, if you don't have any of those, you can get a, say, a surgical gloves. You can improvise some test lung and attach into a endotracheal tube and connect to the ventilator tubing and try to simulate what I'm going to tell you, so that you will have some kind of idea how to change the volume, how to change the rate, things like that. So otherwise, if you just listen to the lecture and then try to practice that one on a real person, that would be sometimes difficult. So its best thing is to test your ventilator, whatever the ventilator you have, with whatever I teach you, and then you ensure that you simulate what you want to, how you want to ventilate the patient on the test lung. Say, for example, if you want to ventilate using a tidal volume or breath volume of 500 at a rate of 12 with certain amount of oxygen. So I'm going to teach you how to do that one, and then you test it on the test lung on your available portable ventilator at least once, so that you're familiar with whatever you are going to do. And then so that you can apply the same thing, preferably with, initially, if you have supervision, that's the ideal situation. Say somebody who knows, you can get help from anesthetist or somebody who is familiar with this thing, so that you can actually get the initial help, and then whoever who learns that one in that unit in the ward probably can help the other fellows, other colleagues in managing. That is how it should go. It's a good idea to teach some of these nurses working every day, because especially if you have a male nurse, you can get them to train, and then so the doctors, when the new doctors come, actually that nurse will be there in that ward for a long period of time, so that even the RHOs, when they change, that nurse would know how to tackle some of the basic settings. So that will be a good idea. Or if you have a senior doctor or SHO, then you can learn, and then you can tell the other RHOs how to do these things. And then one of the most important thing is, not you can set up the ventilator, but what is happening to the patient, the assessment and reassessment. I can't stress that enough. If you just connect a patient to a ventilator and the ventilator is malfunctioning, you have got no idea. So you have to assess the patient, then you will realize something bad is happening. So ventilator can be a life saver. At the same time, it can kill people because there is no free flow of air. And then you must make sure the patient's requirements are met using the portable ventilator. It's not impossible, but I'll just try to simplify. First of all, we'll try to learn how a ventilator delivers a breath. I'm not going to details. I'm just going to simply say there are two main methods a ventilator can deliver a breath. One thing is called volume control, where the ventilator tries to deliver a certain volume. Basically, it's by adjusting the flow and the time, but we forget about those things. The ventilator breath or the breath the ventilator is giving, so it will use either a volume control where you know the volume, you can set the volume, say 500, 450, 300, whatever the set volume will be delivered exactly that volume, so that you can ensure that the patient is getting that volume. The other method is the ventilator sets a certain pressure. So maybe we'll say 20 centimeter water pressure, so that depending on the patient's lung characteristic, maybe if it is a stiff lung, you will get a smaller volume. If it is a very compliant lung, maybe in say COVID patient in delta COVID pneumonia, probably they'll get a very large tidal volume. So you can adjust the pressure to get whatever the tidal volume you want. So remember that all the complex ventilator modes are using either one of these, either volume control or pressure control kind of method. So that there are only two ways of delivering a breath, either volume or pressure. So that is the ultimate basic about the methods of delivering a breath. And then if you actually see some of the old ventilators, you can see they have different modes. Sorry, they actually divide all these modes into two main groups: volume control and pressure control. Under these, you have AC modes, SIMV, spontaneous. We'll forget about all these modes for the moment, but there are two main methods of delivery. You can deliver either volume or pressure. So there are so many, some 300, 400 types of modes, but we are not going to learn all these things, and it's not necessary for you to learn all these modes. If you know simple basic modes, I only use a couple of modes, so that it is enough for you to save a patient. So I'm not going to go into details of these modes, but basically you can think of, a mode where ventilator controls everything. So full control is done by the ventilator, where the patient doesn't have to do anything. The ventilator meets, it delivers certain tidal volume. So you can deliver the volume. As I told you, there are two methods, either volume or pressure. And then it controls, it gives that pressure, every 5 seconds, 6 seconds, depending on the rate you have set. So it will keep on giving breaths. So that's full control. So we call them actually mandatory breaths. You don't have to know this name. Just imagine that there is a mode where the ventilator is controlling everything, all the ventilator requirements. And you can have another one where another kind of modes where the ventilator is delivering whatever the set values, and then the patient can also take breaths in between. So basically the mode we have SIMV, you don't have to know what it is, but at the moment now you have a certain kind of modes where the ventilator completely controls the breathing. And then I'm not going to let you use that mode, so you can forget about that one. And the other mode is, so we have a mode where the ventilator is controlling the breathing. If the patient is not breathing, if the patient is breathing, patient can also take some breaths. So this is probably the ideal mode to ventilate, because, for example, you set whatever the values you want to set. For example, I want a tidal volume of 500 and a rate of 12. The patient want to take 14, the patient can take 14, but I have set 12. And then if the patient stops breathing, so still the ventilator is going to give that 12 breaths. So if you know it, you can actually increase those ventilator component. Patient can look after the rest of that. So this is the kind of recommended one if you want to ventilate. And there is another mode when the patient is strong enough. There is another mode where the patient breathes, patient manages all the rate and how the patient breathes. That's called the spontaneous mode. There are so many names: CPAP mode, spontaneous mode. Just so there are so many names for these things, but you only have to know this SIMV mode. So I would rather ask you to forget about all the other modes and think of SIMV mode for the ventilation. When the patient is strong enough, you can, wean them to the spontaneous mode. So before, I mean, spontaneous mode, that's a kind of a later say. Initially, what you need is to ventilate the patient, try to save the patient from death, and then probably somebody can get in and, you can get some advice and to how to put the patient onto the spontaneous mode. And because I have limited time, I'm gonna tell you how to set up the ventilator and how to save a patient from initial acute period. That is my main aim. So there are three main basic types of modes. I'm not going to talk about the full control ventilator because it can be done with the SIMV mode also. If the patient is not breathing, ventilator will look after that one. So we going to focus on the SIMV. As I told you, there can be two main types: volume control, pressure control. SIMV, you have a volume control, whether you want to give a specific volume or whether you want to use a pressure to get a certain volume. It's up to you. And there are advantages and disadvantages, but SIMV, you have two different modes: volume control, pressure control. Whatever it is, the ventilator will deliver whatever the volume you have set, or if you have set pressure control, it will maintain the pressure and try to deliver a breath. So whatever it is, that is what SIMV is. If you even paralyze the patient, the ventilator part will look after the patient once the patient starts breathing. So the mode will allow patient to breathe. So I would recommend forget about the other mandatory mode. Try to keep the patient on SIMV. It's easy for you guys to remember two modes: SIMV mode, that is what you start with, and then once you have controlled everything under control, then you can think of changing the mode. So even if you remember the SIMV mode, probably that will do for the acute period. So forget about all the other, advanced modes. If you see a portable ventilator, just try to look for SIMV mode and you start with that mode. I'll tell you how to do that. So basic ventilator requirement and settings. So in order to learn now, the idea of ventilation is in COVID is basically oxygenation, and you always have to look after ventilation. That is the carbon dioxide removal. Oxygenation is, providing oxygen into the bloodstream. That is what we try to do with these ventilators. Now, each and every portable ventilator is different by its appearance and how the knobs are located. So it's going to be a kind difficult thing if I try to, teach you some typical portable ventilator or each and every ventilator. So I'm going to tell you how to set up, how to look for very basic stuff. And first of all, so you have to have some idea about the minute ventilation. I told you that is what is required to wash out carbon dioxide. At the same time, it is required for the oxygen also, but basically to control the carbon dioxide and your blood pH levels, the acidosis, alkalosis. When the patient is acidotic, they breathe faster and breathe hard, deeper. And to have high minute ventilation rather than having a simple 6 liters per minute, maybe they'll have 12 liters, even 18 liters when they are acidotic. So minute ventilation. So how do you set that one? So we set each breath tidal volume. So I told you there are two main ways of delivering a breath in ventilator. You can either set a volume in the volume control mode in SIMV, or you can set a certain pressure so that depending on the patient lung characteristics, it will deliver certain volume. You can adjust the pressures to get a volume, or you can set a certain volume to give a tidal volume. Simple as that. And then to match the minute ventilation, so you first set the tidal volume. If the patient had been breathing very rapidly, it's better set that rate initially to a higher value. For example, if somebody is breathing at a rate of 60 breaths per minute, they are taking very deep breaths. Don't simply set a value of say 350 tidal volume into rate of 10 or 12, because that patient had been breathing harder. So you watch the patient before you set the ventilator. If the patient is breathing faster, try to simulate the patient's breathing pattern initially, and then you can change. So that is what I usually teach. That generally, if you look at a guideline in a standard ventilator guideline, if you read some non-COVID kind of guideline, so they ask you to start with the normal kind of setting, so tidal volume 500 or some kind of 8 ml per kg, and then the rate of a normal rate. But if the patient is dyspneic, too dyspneic, then you have to start with a higher respiratory rate. And then, okay, now you selected a mode and selected certain minute ventilation, okay, in your mind, and then you set a tidal volume and have a certain rate. You don't have to be exact. You can always evaluate the patient and then adjust the settings. And the other thing is oxygen concentration. I have seen some people, for non-critical care people, they don't know this FiO2. So percentage of oxygen can be mentioned as a percentage. For example, if you say 40% oxygen, so the same thing can be used. In certain calculation, we use FiO2 is a fraction of oxygen out of 1. So from 0 to 1, sorry, not percentage, 0 to 1. So if it is 40%, it's 0.40. That is 40%. If it is 50%, 0.5. If it is 100%, 1. Things like that. So FiO2, this is important in certain calculation. If somebody says PF ratio, PaO to FiO2 ratio, this is what you use. You use this value rather than 50%. But the same idea, percentage and FiO2. In certain, for example, in this ventilator, it says FiO2 from 40 to 100 in this ventilator. Now, setting up, how do you set the oxygen? Sometimes it is a knob like this. Sometimes you have a separate oxygen controller at the side of the ventilator. I'll show you. So that's how you have to know how to set up the oxygen. So we set the tidal volume and rate, and then we learn how to set up and then some kind of baseline pressure, we call it PEEP. And we'll just simply mention about PEEP. That's baseline pressure. Generally, you can set the PEEP to 5 if you don't have any idea. Remember that value. PEEP is positive end expiratory pressure. That is what maintains pressure. The pressure goes up and it comes down to this baseline pressure. So that is important to keep the lung inflated and recruit some of these alveoli. But if you don't know about PEEP, just remember the value of 5. When you set the ventilator, keep the PEEP at 5 if you don't know anything about PEEP. But otherwise, if it can be changed, as I told you last time, the EPAP or CPAP. So you can increase that one to have more oxygen, more oxygenation. So that is the baseline pressure. And then we talked about the modes. And there is another parameter which is called maximum pressure limit. That is what protects the lung. So if you can set that one, here of course in the ventilator it says 20 to 60. So you can go up to 60 is a very dangerous pressure. So generally you keep it somewhere depending on your pressure needed. Sometimes in a normal person maybe 35-40 is okay, but certain times you may have to increase that one in a desperate situation. But basically try to keep it 40 or less the maximum. That is not the pressure the patient is getting, but that is when by chance if the patient is coughing or patient is trying to forcibly exhale or some other obstruction, the ventilator will not go above that. Say this is a safety limit. This is not what the patient is getting. So these are named in different ways. So you will have to get the idea and see in this one says P max. So some ventilators they say P limit. There are so many other names, but have some idea and look at your ventilator and just fiddle around the ventilator and just try to find out what it is. So first of all, the setting up the oxygen. So it may be, if it is not available in a menu in the ventilator touchscreen or any other menu, maybe look at the side of the ventilator to see. So this is actually a Newport portable ventilator where you have a oxygen mixer. Mixer where you can actually adjust manually. You can set 21%, 40%, 60, up to 100%. So you can adjust the FiO2. So if make sure that if it is not available in the menus of the screen, probably check around the ventilator to see whether there is a manual oxygen control. So that is how you set up oxygen. So that is very easy. You either look at the menu, see where the oxygen is. You can probably touch it and probably adjust it using certain buttons. So depending on the ventilator, that will change, but it is not that difficult. So you see the, and probably within a 3-4 minutes you'll figure out how to set up the oxygen. So it may be, as I told you, in a menu buttons where you can just press it and probably adjust it using one of these buttons, or maybe there is a rotary control where you can rotate and adjust the value. That is, you can actually figure out that one once you are with the ventilator. Now the basic steps, what I'm going to tell you, I actually made a mnemonic. I don't know whether you will be happy to use this one. I just made it this afternoon for you guys to remember and not to miss all these novice people. So first one is the M, mode. So I told you you can use, you have to use SIMV. If you, that is the only mode I want you to start with. There are so many modes, but forget about all the other modes. Try to find whether you can set the mode to SIMV. If there is a mode button, press that one and see where the SIMV is. And you select whether you want volume control, whether if you want to give a certain particular volume or you want to give a pressure. So you can select SIMV, volume control, or pressure control, depending on. So I would recommend, if you don't have any good experience, try to go for volume control. Then you can select the volume you want. For example, if you want 450 ml, so you can set that one. The pressure one is good for advanced people, but for example, if the patient the lung condition worsens, the lung becomes stiff, the volume you initially set will change. It will come down. So this is a problematic area. So I would rather like you to use volume control if you don't have a lot of experience. But if you have experience, go for pressure control and keep changing the pressure level. So that is also possible. So basically, SIMV, volume control, you set the volume. And then tidal volume, sorry, mode, and you set the tidal volume like that. MT, R means respiratory rate. So you adjust the rate, as I told you. If the patient is dyspneic, start with the higher rate, probably 20 or 20. I mean, I sometimes start with the high value, but generally don't go above 35, 40, because that might, so you'll have other problems like air trapping. I'm not going to talk about those things right now for the moment. So respiratory rate. So MTR. O means the oxygen. Oxygen, how much oxygen to give, that will depend on what is your oxygen target. If a patient is saturating, say 88%, and you want to get it say 92% or something like that, then you gradually increase whatever the existing amount of oxygen. You can adjust. So you can actually initially start with 100% if you want, if the patient is in a pretty bad shape, or FiO2 of 1. So if your ventilator says FiO2, look, increase it to 1. If it says oxygen concentration, you can increase it to 100% to begin with in a very bad hypoxic patient. And then later on, you can slowly come down. The idea is to maintain oxygen concentration of 60% or less to minimize the oxygen toxicity. But in a critically bad patient, it's best to start with 100% oxygen to begin with, because the patient is hypoxic. And then the PEEP value. And I told you PEEP value, if you don't know, you can set it to 5. Or if you want to increase more, have more and more oxygen, recruit more and more lung tissues, then you can gradually increase, maybe 8, maybe 10. I would advise not to give it more than 14 if you are a beginner. And even for advanced people, I wouldn't think, I mean, more than 14, some people use, but it can actually cause a lot of damage, especially with this L-type pneumonia. So it's best to use the minimum PEEP needed to achieve your oxygen target. If your oxygen saturation is 94% with PEEP of 8, I mean, you can recruit more lung tissue, but so in the ward setup, I would not increase the PEEP more than 8, just because a certain guideline in a non-COVID environment, the previous guideline says to have a, if you have FiO2 or this one have that much of high PEEP. So I would generally advise you to have a lower PEEP, but try to maintain saturation. If saturation is achieved, don't try to maximize it to 100%. by giving very high PEEP. That is one advice I want to give. And there is another thing called pressure support, which I don't think I would discuss right now at the moment. But for the moment, PEEP, and you read about pressure support because I don't have enough time to go through these things. And PEEP and I is the IE ratio. Make it 1:2. I don't usually recommend setting one IE ratio, but here for easiness and for safety, I would ask you to set this one to 1:2. If you are a beginner, don't change it. If you are a beginner, keep the PEEP at 5. Don't change it. But if you need more oxygen, you can gradually increase. So entropy. So you go to a portable ventilator, try to these, set these 6 parameters, and even if you have thousands of other parameters, you will probably get away with this basic 6 settings. So it's not that difficult. So that will make your life much more easy because you only have to figure out 6 things. Even if the ventilator has got so many intimidating parameters, just try to figure out these 6 things. And then remember this entropy value, mode, tidal volume, rate, oxygen, PEEP, and IE ratio. So last 2, you can just set a default value. Oxygen, you can start with the 100%. That is also, you can set default value. Only thing you have to figure out is SIME volume control. You can start, the mode is also fixed, the tidal volume and the rate. So that is what so it is easier for you guys, for the all novice people. So you only have to figure out the tidal volume and the rate, and rest of the thing is SIME volume control, oxygen, PEEP of 5, I ratio 1:2. Then you can probably later on change. So the other thing is, important thing is assessment. Always try to figure out whether the oxygenation has improved. What is your target of oxygenation? Don't try to over-correct the oxygen. Don't try to achieve 100% in the ward setup, because all these with high pressures, with high PEEP, very high PEEP. So try to be happy with 94%, 92%, depending on different scenarios. You will have to maybe be happy with a lower oxygen, but at the moment, 94 is enough for a ventilated patient. Don't try to make it 100% by giving very high pressures and very large tidal volume. And then you can adjust the tidal volume and the rate to achieve your carbon dioxide target, especially in a sedated, paralyzed, or ventilated patient. Don't worry too much about the carbon dioxide if your pH is okay. But there are so many values. pH is normally 7.35 to 7.45. But don't overcorrect it. So a lot of people think acidosis is bad, alkalosis is much better than acidosis. Yeah, that is basically true. But in a hypoxic patient, acidosis is sometimes say 7.2, some say 2.5, something like that. Maybe actually help unload oxygen at the tissue level. But if your pH is 7.6 with the ventilator settings, I have seen these things. So that actually is a very bad combination in a hypoxic situation. It will improve your saturation value sometimes, but it is actually harmful. It is not allowing oxygen to be delivered at the tissue level. So have a 7.25 or above is okay, but don't try to lower it down to 7.25. But if you need very high ventilator settings, probably be happy with 7.25. Don't try to give too much bicarbonate unless the patient is having very severe acidosis. So those are the kind of things I want you to consider. The targets, you have to set it up. Probably you talk to senior colleagues to set up a certain pH and carbon dioxide target. You can talk to the ICU people in the hospital, and they'll give you a certain target to maintain. If you're doing blood gases, if you're not doing, just try to go with the saturation, and then try to maintain above 94 is basically okay. Don't try to use very high pressures, very large tidal volumes to achieve more than 94. It's very important. And oxygen delivery, because of the time limitation, I'm not going to talk about these things. And the other things, if you have to be aware of, which I don't have time to go through. Basically, you have to make sure that the lung is looked after well, maybe physiotherapy, maybe clearing of secretions. The intubated patient, they need some amount of, care. Probably in the next lectures, somebody's going to talk about that one. And infection prevention and exhalation port. One thing I wanted to tell, some people, I have seen some other groups of people, they try to improvise certain things to kill viruses coming out of the exhalation port. Don't attach anything, any longer tubings, and hanging onto the dipping onto the fluid columns. I mean, you can do that, but if you know what you are doing, but it can harm the patient. And this, don't ever use these heated elements at the exhalation port to kill viruses, because oxygen and these high temperatures are not really, safe way of managing. Uh, so you don't attach anything to the exhalation port, because when you don't know about the ventilator, so when you may be worried about the all the gases coming out, and people do various things, especially in certain parts of, less experienced people don't try to temper the exhalation port. So I'm going to show you certain portable ventilators. So I told you entropy, um, entropy. So mode, you can select certain modes. So you can select. So here, see, actually in this mode you have section, but say mode SIMB over here, volume control. So this is what we basically want. So you can actually look around the screen to figure out where the mode button is. If it is something else, change it to SIMB. If it is, you can change it to volume control, and then it will give a certain volume value. So you figure out where the volume is. This one says VT, that is your tidal volume. So this says 0.35, that is in liters. So you can set the mode, set the tidal volume, and you can set the rate. Rate maybe they will say RR, respiratory rate, or sometimes they say F is the frequency of breath. So you set the rate, and oxygen probably over here or on the side, you can set oxygen, and you can set the baseline pressure or the PEEP. Here you have the PEEP, you can set the PEEP, and the IE ratio. Here it says inspired time, and in certain screens you will see IE ratio, but if you can't figure, just you can actually omit that one. But in certain screens you can actually see the IE ratio. Once you change this one, you can change IE ratio. So this is where the oxygen mixer is. So this is another old ventilator. So you might sometimes, so once again, it's easy. You go for entropy. Entropy. So mode. So this is where the mode is. You just figure out where the mode is, and then try to see where the tidal volume is. So this is where the tidal volume is. Once again, is 0.35, means 350 ml, and rate. Here it says frequency F, and you see where the oxygen is. Most probably it is on the side of the here. So you can change oxygen, and then baseline pressure PEEP. You have the PEEP, and then IE ratio. You have IE ratio here, and you can. So that is what. So all the other parameters, even if you don't, do anything, probably you can manage fairly okay. So this is another ventilators. Once again, tidal volume. You can change the modes over here. So you just to figure out by looking at the initial screens, mode, rate. You have the rate here, IE ratio here. You have the PEEP here. You have oxygen here. So that's not difficult once you know this entropy. Probably you can do manage the initial settings, and then later on, if you have time, you can read about these certain things. Probably you can save this patient by setting these values. So this is once again another portable ventilator we have in Sri Lanka, Hamilton Medical. So they are also I mean, it's kind of a advanced one. Probably you can do all ICU ventilation with this portable ventilator. That's what I do in my ICU. And this is another portable ventilator. Once again, you set the mode, SIMV volume control. So, and then, oxygen, tidal volume, things like that, tidal volume, oxygen, you can, change all these values, and then start ventilating with the ventilator. So you will have to learn your ventilator, but these settings. So once again, this is another Draeger ventilator. So entropy, once again, mode, you can see the modes over here, and tidal volume, you can see the tidal volume over here, R, respiratory rate, oxygen over here, and pressure, baseline pressure is not mentioned over here, but once you, this is booting up. Once you see, you will see the PEEP and the IE ratio over here, and you can set up. So entropy. So I'll just finish with the typical case scenario. This is a 60-year-old male person, 5 feet 6 inches. There is a way of setting the tidal volume according to the height, which you will have to, it's 2.3 h. This height in inches minus 60, and you add it to 50 in a male person. But even if you don't know, So in averagely built people, generally the body weight is roughly equal to this, what is this called predicted body weight. But in extreme situation, very thin individual, smaller individual, probably you will have to figure out using one of these formulas. But basically, tidal volume, generally we start with 8 ml per kg tidal volume, and then you can reduce depending on the this thing. And this patient is failing to achieve oxygen, and somebody decided to intubate, and they intubated with rapid sequence intubation. And then what are the settings we are going to check? Once again, I told you how to set entropy. Look for the mode. So you set SIMV volume control. You try to figure out how to set that one. And tidal volume is 5 feet 9 inches, probably I will say 660 kilos, and then you multiply that one by 8, so 480 ml. So 500, that is okay, but don't try to apply any tidal volume above 600, which is can damage the lung. And the respiratory rate, depending on the patient's respiratory rate. Patient had been breathing very rapidly, maybe 60, then you don't try to set 60, but at least as 20, 25 is should be a good this thing, because if the baby patient is not taking this large tidal volume, so you can probably get away with the lower rate with the significant tidal volume. So respiratory rate, entropy, oxygen, and you start with 100% in a if you don't have a lot of experience, and then you set a PEEP of 5 if you don't have enough experience, and then you can slowly increase to achieve more and more oxygen saturation. So I ratio, if you don't know, set it to 1:2. If you can't find, just leave it alone. So that is the simple ultimate basic steps. This is not the way you ventilate in a normal. So this is not my teaching, but this is just for ultimate novice people. If they really need to ventilate a person, but you don't have any expertise around, and you have to change the settings. This is the ultimate basic settings you must select. Once you set these values, there are other parameters like trigger values, slopes. There are so many other parameters, but you don't have to worry about those things to save a person. But it's important to set the rate, volume, and the rate. Volume, don't try to set a very high value, and don't try to achieve 100% saturation. It's extremely important. And then by doing so, don't increase very high PEEP, very high tidal volumes. Just try to get your target from somebody who has experience, like from an anesthetist or ICU doctor in the hospital, and then manage. So I don't have enough time. I just go through minute ventilation. If you want to change the minute ventilation, like control the pH and carbon dioxide, change in the volume control mode. You increase the volume and increase rate if you want. And pressure control mode, you will have to adjust the pressure levels and the rate. Spontaneous, I didn't talk about. And then to increase oxygen, first you increase FiO2, but that will not help any underlying problem. If, say, for example, if you have atelectasis, it won't increase, it won't help atelectasis. It might even worsen it. And PEEP is the one which is most important, when especially if you want to increase FiO2, anything above 0.6 or 60% oxygen, then you think of increasing your PEEP as a general guide. So this is a general guide. This is not a guideline. If you need to give more than 60%, you must do something. Something bad is happening to the patient. So maybe a good idea to increase your PEEP, but they get some advanced help also. And I don't have time to go through oxygen. So and lastly, the last thing I want to tell you, and this lung protective strategies, they have to be started right from the beginning. Don't let the patient have very high tidal volumes of 1000 ml, 800 ml, and don't try to, don't expect the ICU doctors to manage this patient right now. When the patient comes to the ICU after they say 5-6 days of large tidal volume ventilation, the damage has happened. It's very difficult to save these people. So the lung protect strategy has to be started right from the beginning when you intubate. So that's what I have so far to talk about. So I hope you learned something from this portable ventilator lecture.